And I want to welcome everybody to the 15th Annual Kawasaki Disease Symposium. We are delighted to have you joining us from all over the US and maybe all over the world. And we will have a simultaneous translation for you today for those of you who are native Spanish speakers. I am hoping
Tenemos
to
aquí el
advance my
traductor en español.
slides.
Bienvenidos a la junta de 15 años de los pacientes de Kawasaki, de la enfermedad Kawasaki. Es una junta anual que se hace para los padres de familia.
Having a little technical difficulty in that I cannot advance my slides.
Técnicos, vamos a tratar aquí.
There we go. This is a housekeeping detail about how to access the Spanish interpretation. So there should be a little globe at the bottom of your screen. And if you click on that, you can choose whether you want to hear the discussion in Spanish or in English. And then click on mute original audio if you want to hear just the Spanish translation. Otherwise, you'll hear the original English that we're speaking in on a lower volume. For those of you who would like to ask questions during the discussion, we've got a button for Q&A. There won't be any way to have a live chat, but we want you to submit your questions. Dr. Tremoulet and Amelia Bento, our data manager, are going to be monitoring the chat, rather the Q&A. So please do send in your questions, and we'll get to those. We have two very robust Q&A sessions during this morning, and we really do want to hear from you. This is the lineup for today. I will be speaking briefly first with some introductory remarks. Then we will switch to Kirsten Drummer, our pediatric cardiology team member. Then we will hear from Hao Wang, who is a bioinformatician working with our group. I will come back in between the two of them. Then there will be a Q&A session, and we'll hear from Audrey Tremoulet, our other clinical team member and clinical trial specialist. And then Angie Rodriguez Verdin is our adult KD coordinator, who will be speaking about the adult KD study. And we will end with a very exciting presentation from a research associate in our climate team, talking about some of the really interesting work that they've been doing, trying to figure out the cause of Kawasaki disease. And thanks ahead of time to Lucia Acosta, our wonderful Spanish interpreter, who makes this available to a broader audience. We're delighted to be able to offer this. So this is the agenda that I've just gone through, but I think we'll go ahead and move along to the talks. So my job is to give you an update on what's been going on, and Amelia, our data manager, prepares these wonderful slides for us. And here you see a red dot for the date of onset of every Kawasaki disease patient. Now, we all know that during the pandemic, strange things happened and Kawasaki disease disappeared. So we know that the strategies for mitigating the spread of SARS-CoV-2, the COVID-19 virus, also affected the spread of Kawasaki disease or the exposure to the Kawasaki disease trigger. And we talked about that a lot last year. This year, what we're seeing is a lot of respiratory viral disease that's not COVID, not SARS-CoV-2, but I think that we haven't quite settled into our normal seasonal pattern of Kawasaki disease yet, but we'll see what happens. But what I wanted to focus on here in the gray dots, these are two missed Kawasaki disease patients. And what I mean by missed is that these children presented so late that they were beyond the period of acute inflammation when we really want to diagnose and treat children with Kawasaki disease. And they were evaluated in our clinic, and we'll talk a little bit more about what missed Kawasaki disease looks like. I'm very happy that there are only 2 gray dots in the last 6 months. And when we looked over time, it does seem that the uptick in Kawasaki disease prevalence in the community then also results in some missed cases. So it fluctuates up and down depending on how many cases we're seeing. But we're thankful that in the last 6 months, we're only aware of 2 missed KD cases. So I wanted to talk a little bit about this problem. And obviously, the way to combat this is to have increased awareness on the part of pediatricians, urgent care clinics, and our emergency room about what the features of Kawasaki disease are, because fully half of the children who were missed actually had all of the features of Kawasaki disease and could have been diagnosed earlier. So here's what the numbers look like over the period of time when we've been collecting data here at Rady Children's Hospital. So in our database, we have records of 2,577 patients that we've seen over 20 years. And of those, 116 or 4.5% were these missed patients. And in terms of their age of onset, it was pretty typical, 3.8 years. So not so different from the typical age of our Kawasaki patients, but there was a broad range of children and age spectrum. The illness day at diagnosis, meaning when they came to our clinic and were retrospectively diagnosed with Kawasaki disease, was on the 26th day of illness. And you can see some people were even out as far as 50 or 60 days. So clearly, this is not what we aspire to. But on the other hand, if you think about the large number of Kawasaki disease patients where we do make a timely diagnosis, we have to credit our emergency department here at Rady Children's Hospital with really being on the ball and catching the large majority of these children. So when you think about how was it that we were the detectives that figured out, oh, this is missed Kawasaki disease, and how is it that these children got to our clinic so we could evaluate them, it was because roughly 95% developed the very characteristic peeling that begins on the fingertips or toes right under the nail bed and then goes down the pad of the finger or the toe. And it's such an unusual feature, and it's so specific to Kawasaki disease that prompted the referral to our clinic. So 95% were ascertained, were referred to our clinic for the chief complaint of peeling. And the most important thing is that only 2 patients out of this 116 number actually had an echocardiogram that was abnormal and required treatment. Now, that ratio of children, 2 out of 116, is much lower than what we would normally expect for children who might suffer heart damage without treatment. We know from the pre-IVIG days that 1 in 4 children would suffer important heart damage. So were these missed Kawasaki disease patients perhaps a milder version of the disease, and that's how they slipped through the cracks? That's one possibility. And I think probably the major explanation, but we absolutely can't say for sure that we made the correct call when we said they were missed Kawasaki disease patients, because as you know, there's no single blood test that we can do that will diagnose these patients for sure, particularly at this very late point in time. So it's hard to find Kawasaki disease. We know this. Here are a number of children who marched through our emergency room with some variation on the theme of Kawasaki disease. So they had fever and rash and red eyes and red lips, but only this child actually had Kawasaki disease, and everybody else was diagnosed with something else. So it is the needle in the haystack problem. And we're really grateful to Mike Gardner, who is now our lead in the emergency room. John Kenegai was there before, but he's retired. So Mike has taken over, and he's created this list of important questions that the emergency room staff and clinics and other people evaluating these patients should be asking in order to make the diagnosis. So an open-ended question: did you notice anything different about the eyes? Have the eyes been bloodshot? Was there any pus or weepiness to the eyes? And there's a whole list here. And Dr. Gardner is actually going to write this up as a publication to help emergency room doctors make sure not to miss these Kawasaki disease patients. So I think this is a really helpful aid that we want to put out there. It will also be on our website, so people can access it there. And this is work in progress, so we're all putting our heads together about the list of questions and what it should look like. But here's the current version. The other thing that we're really working on developing is patient-facing information materials. And again, all of this will be posted on our website. And we had the pleasure this last summer of having Cameron Kimura join our group. Cameron's headed to medical school, is in the Brown program at Brown University. And she spent the summer working with Hao Wang and others in our group and had a number of different projects, but one of them was putting together the peeling handout that we have here. And this is going to be in our emergency room, because sometimes there are patients who come in who have some of the features of Kawasaki disease, but it's not quite there yet. So maybe they have a rash and fever, maybe the lips are a little red, but the laboratory features, if they get blood drawn, doesn't scream Kawasaki disease. But we want to make them aware that sometimes the signs and symptoms disappear and are never really full blown, but then the peeling can happen as a late feature. So we know that only 2/3 of Kawasaki disease patients peel. So this isn't a 100% safety net, but at least it gives the parents a clue of what they should be looking for. And so it explains what that peeling looks like. And then even later in the course of the disease, children get these dents across their nail. As you see in the picture here, these are called Bowes lines. And this horizontal groove represents the portion of the nail that was being formed when they had the severe inflammation, and the collagen cross-linking that makes your fingernail was actually disrupted. And so that's a very late sign. So usually 6 to 8 weeks after the acute illness, the beginning of the acute illness. So these handouts will be on our website. When we see patients referred with this kind of peeling, we obviously want to do laboratory studies to see where they are in the course of inflammation. And if we see important inflammation, then that's a reason to treat, even if the fever is gone. Because what we're really trying to do with the treatment of Kawasaki disease is prevent the heart damage. And we know the heart damage is related to the inflammation. And of course, we definitely want to get an echocardiogram to assess the coronary arteries and see if there's been any damage. And again, those children would be treated. So any inflammation that's persistent, any abnormality on the echocardiogram might prompt us to admit and treat that child, even if the fever had resolved. So here's another handout that we've developed, and this is also posted on our website. Takei Soda was a student who came to us from Japan. He's a medical student in Niigata University, and we were delighted to have him working with us. And what we wanted to have was a handout that we could give to our 15 and older children who were having what we call an exit visit from our clinic. And at that exit visit, we do a complete cardiovascular assessment, but we do a lot of counseling for the kids. At that point in time, we feel that they're able to understand genetic counseling to a certain extent. So we talk about the genetics of Kawasaki disease. We talk about the American Heart Association recommendations for a heart-healthy lifestyle. So we go through blood pressure and exercise and diet and all of those features. But at the same time, we want to give them a piece of paper that tells them what their personal experience of Kawasaki disease was. So we fill in the age at which they first had their Kawasaki disease, and then we fill in the details here. So we feel like it's important for children to understand that they had Kawasaki disease and to have something they can hang on to as they go forward in life. So they have a memory or documentation of what happened to them. Another handout that's also on our website and can be accessed there was made by Sam Kong, who was initially a med student here and now an internal medicine doctor. And when Sam was a student, he created this Z-score handout. When we do our echoes, we measure the internal diameter of the artery, the coronary arteries as shown here, and then we take the patient's height and weight and we normalize that measurement for how big the patient is, because how big your coronary artery should be depends on how big you are. And so we put it through an equation and then we plot it on this bell-shaped curve as what we call a Z-score, which is this normalized internal dimension. So for those of you who have children with aneurysms, you've certainly heard us talk about Z-scores, and this handout is available on the website. So we all know these red flags of Kawasaki disease. This is what we don't want to miss. And we have some links for more information if you want to use these QR codes. The KD Foundation website, and a shout out to the KD Foundation for the support that they give every year to our hosting this symposium for parents. It's all virtual this year because last year we tried to hold a hybrid event and only very few big parents came. So we've decided that you voted with your feet. If you really strongly want us to go back to in person, you can always email me or reach out to us through the KD Research Center website and email address to let us know that you want us to go back to in person. But I think for now we're going to stay virtual so you can stay at home and have your cup of coffee while you learn something about the new research that we're doing in Kawasaki disease. So these are our links that may be helpful to you. And I'm going to stop sharing my screen now and turn it over to Dr. Kirsten Drummer, who's going to talk about a new project that she's working on.
Okay, hopefully you can see my screen. Thank you, Dr. Burns, for the introduction. I am Dr. Drummer. I'm one of the cardiologists and I have the pleasure of working with the Kawasaki team at Rady Children's Hospital. So today, what I was going to talk about are the outcomes in the babies and the little infants. So anybody who comes to us at less than 6 months of age, that's who we're going to be discussing today. So who are the Kawasaki patients at highest risk of aneurysms? As you know, aneurysms is one of those outcomes from Kawasaki disease that we all worry about and want to prevent because obviously the heart is a really important organ. So the patients who are at highest risk are those that are not treated. So if you have Kawasaki disease and you aren't treated, then there is a risk that you will have coronary aneurysms up to 25% of the time. Patients who get missed, like Dr. Burns was just talking about, and get treated late outside of 10 days of illness are also at higher risk of aneurysms. Infants, particularly those babies that are less than 12 months of age, even if they are appropriately treated within 10 days of illness, are also at higher risk of developing aneurysms. And then patients who have an initial echocardiogram in the hospital that is not normal are also at high risk of developing worsening aneurysms. And then there's certain racial groups like Filipino and Vietnamese that tend to have higher incidence of coronary artery aneurysms in Kawasaki disease. So Z-scores are something that you're going to hear a couple of times today, and often we talk about them in clinic, but a Z-score, like Dr. Burns was talking about, is a very specific measurement of the lumen, or the inside of the vessel. This is what we're actually measuring on the ultrasound of the heart or the echocardiogram. And then we index it or normalize it for body surface area. And so there is a big equation, but basically, if the way I like to think about it is a Z-score of 0 is the average of the average. So it doesn't get any more, just kind of in the middle of the road. And people are allowed to have kind of different size coronary arteries. You can have up to 2 standard deviations above the average and still be normal. And you can have below 2 standard deviations and still be normal. So anything between -2 and +2 is kind of 95th percentile above or below can still be normal. But once you get outside of that 95th percentile, then that's generally not normal. And so if you have a Z-score of +2 to 2.5, that's kind of mildly abnormal. And if you have a Z-score above +2.5, that's in the aneurysm range. And we're going to get a little bit more specific about that. So the normal distribution is between -2 and +2. Mild dilation is +2 to +2.5. Small aneurysm is +2.5 to 5, medium +5 to 10, and then giant aneurysms are Z-scores above +10. That's very large vessels. And this is a CT scan of a patient who was treated elsewhere, but came to us for a second opinion. And now he's a teenager, and you can see this very dilated portion of this coronary, which he still has giant aneurysms. And then unfortunately on this side, this other vessel, which is the right coronary, he had a very large aneurysm here that then clotted off. And so there isn't any flow that gets actually all the way through. This particular patient has tiny little vessels from this left side that then give blood flow and perfuse the right side. And he has normal heart function, and he played sports. And with the right medical therapy and follow-up, these patients can still have an active and a normal lifestyle with their medications, obviously being quite important. So the outcomes in our institution, so these are just the babies that we have treated. We have seen 44 infants less than 6 months of age over almost a 10-year period. So these are the last 9.5 years. All of these infants who came to Rady Children's Hospital were treated within the first 10 days of the fever. 64% were female, and the median age was 3 months. So some of the babies were even younger than 3 months. That means obviously up to 6 months of age. And the median day of illness at the time of their treatment of Kawasaki disease was 5 days into the illness. And this is really a shout out to the general pediatric community and the pediatric emergency room physicians who have a suspicion of Kawasaki disease, refer the patient, and the patients get diagnosed in an extremely timely fashion, which allows us to start treatment early in their course. So who are these babies that we've admitted in the last 10 years? Really, it reflects the population of San Diego County. So the majority of the patients that we admitted were Hispanic, Asian, and more than one, identified with more than one race. So the clinical data, 55% of the babies on their very first echocardiogram had abnormal Z-scores. So not only is their age putting them at high risk, but also having an initial echocardiogram that is not normal, that also puts them at high risk of developing aneurysms. And so these shaded areas are the babies that had abnormal echocardiograms, and this red is the worst in terms of medium aneurysms. This darkish purpley blue is kind of small aneurysms. And then this blue down here is just mild dilation. But nonetheless, over 50% had an abnormal echocardiogram from the onset, from their initial echo. Now, some of these babies get worse, right? Because it takes time to quell all the inflammation. And so there were further abnormalities during the hospitalization that we kept trying to get on top of. And so you'll see this category of medium aneurysms increase, the category of small aneurysm increased, and this mild dilation kind of shifted, but also some babies developed that as well. So 66% of those infants ended up having abnormal coronary arteries at some point during the hospitalization. And what we do is we give IVIG, we start IVIG first, that's the first therapy, and then immediately following IVIG, we give infliximab. Sometimes we actually do it the opposite direction, depending on how long it takes us to get the IVIG. But the point is the infants less than 6 months of age with abnormal coronaries, you just have to keep giving medication until those coronary vessels stabilize and they stop changing. So we use infliximab as a medication that some of you have heard of. We use anakinra, which is a medication that is subcutaneous that some of the babies have been on. We use cyclosporin, and we use them in succession until the coronary vessels stop changing. We're very, very, very aggressive about that. And this whole notion of doing it quickly is important. You can't wait 3 days or 10 days or wait and do another echo in a week. You have to figure this out every 24 to 48 hours and add medications. And this is where we ended up. So when we look at all of these infants at 1 year out from their illness, there's no more red. So nobody had medium aneurysms. And there's just a small part of this pie chart of patients who either had small aneurysms or mild dilation. And so this is really a huge success and is really a stunning outcome to something that could have been a lot worse without the knowledge of immediate additional therapies. So this is another way of looking at that, but initially this is where the babies were. This is how bad they became or the worse that they were. And then at 1 year, everybody seems to be doing quite well, and nobody had a Z-score greater than +5. So that's really remarkable. Nobody had medium aneurysms, nobody had giant aneurysms at a year out from the illness. So this is called early intensification of therapy. So adding medication early in the disease may help prevent the complication of giant aneurysms. And basic science is what helps us to know which medicines to give at which point of the inflammatory process. So that's why we're pretty particular about when we give infliximab, when we give anakinra, when we give cyclosporin. And you'll notice that we do not use steroids in our institution. We don't use steroids. So once a child has giant aneurysms, there still is a chance that they can regress. And there is a small percentage of patients that even though they have this dreaded outcome of giant aneurysms, that over time, there's something about their bodies and such that they will regress to have normal coronary arteries by CT scan 10 years later, 20 years later. It's a phenomenon that we still don't understand, but we do follow some patients where that has happened. Obviously, it's not going to happen probably in this patient because he's now 18 or a young adult. But even if the aneurysms stay with adequate medical therapy, patients can have a good quality of life and not necessarily require an intervention. This child has not had any intervention surgically or transcatheter. So in conclusion, having a high index of suspicion is the key to making the diagnosis in a timely fashion. And all infants less than 6 months of age with unexplained fever and abnormal labs with these elevated, very elevated inflammatory markers like CRP and SED rate, even without clinical features, should get an echocardiogram. Because as you know now, if an echocardiogram is not normal and you're less than 6 months of age in Kawasaki disease, that's a high-risk patient. And so this is stated in the guidelines and about Kawasaki disease. And an abnormal echocardiogram initially on that very first look may be the best marker for patients at high risk. I want to say thank you to all of our patients and families and the research teams. Happy to entertain questions after. Stop sharing.
Okay, we're coming back. Thank you, Kirsten, for that presentation. And I will share my screen and move on to the next topic, where I'll be speaking about some of the new ways that we have to study and try to understand what's happening in the body during Kawasaki disease. So doing a little molecular biology for you here. This may not be a conversation that you have very often, but let's go over a little bit of basic biology. We have ways of looking at DNA, which is a way to understand Kawasaki disease susceptibility. So DNA is the genetic code in all of your cells. And there are changes or a pattern in that DNA that determine whether or not someone is susceptible to Kawasaki disease. Our current understanding is that you're born with a genetic pattern that makes you susceptible. And then at some point, you don't get very far in your life because 85% of our patients are under the age of 5. But at some point during those first years, you're going to breathe in, and we do think you breathe it in, a trigger that sets in motion Kawasaki disease. So we can look at the DNA, and we are looking at the DNA to try to understand what that complex pattern is. And thank you to our families who have helped us with those genetic studies. DNA is then transcribed into RNA. And RNA, I like to think of as a way to understand what the cell was thinking. So it's the active part of starting to make proteins. It's the first step along that path. But there are lots of RNA molecules that actually have their own function. They don't need to turn into protein. They can do jobs all by themselves. So when the cell is making these RNA molecules, it's a window into what that cell was thinking or reacting to. And then finally, that RNA can be translated within the cell into proteins. And understanding what protein cells are making helps us to understand a final part of the biology and the pathway. So a huge shout out to the Gordon and Marilyn Macklin Foundation, who with a large gift to the research center allowed us to take that gift to Illumina. Illumina is a large company right next door to the UCSD campus that is one of the leaders in sequencing. So sequencing means you actually go in and you unravel the genetic code and you look at each of the components, each of the molecules that make up the billion elements that then determine our genetic code. So with the donation from the Macklin Foundation, we were able to match that with Illumina, who was very interested in generating a large data set of DNA on Hispanic Kawasaki disease patients. And why specifically Hispanic? In previous studies on the genetics of Kawasaki disease, the control group, so the group that you compare your Kawasaki disease patients to, those control groups were really only robust for European descent people. And that meant that we could only analyze the sequence from Kawasaki disease patients who were of European descent. And so that means that we excluded all of our Hispanic patients, we excluded all of our Asian patients, and we really could only focus on a small subset of our Kawasaki disease patients. Now, here in San Diego, where we'll take care of, on a usual year, 80 to 100 new Kawasaki disease patients, the majority of those patients are Hispanic because we live in an under 5 years of age Latino majority community. So there are more Latino children than there are any other flavor of children. So it certainly made sense that this was an unmet need, that the Hispanic community had been excluded. But now, thanks to the work of Illumina, thanks to the work of the NIH, there are robust data sets where we can compare our Kawasaki disease Hispanic children to normal Hispanic children, or that is children or adults, your DNA doesn't change, but populations who never had Kawasaki disease. And that's the key to being able to do these studies. So our team, Ji-Hoon Kim, Hao Wang, and we'll be partnering with lots and lots of other teams across the country and across the globe, actually. We've taken possession of about 180 terabytes of data that has been generated at Illumina. And the next couple of years are going to be an explosion in knowledge. And we're really excited about this and excited about meeting this gap in understanding about the genetics of Kawasaki disease. So RNA sequencing can also be done where we actually look at every molecule across the entire sequence of the RNA. And this can tell us about cellular responses, which genes are upregulated and which genes are downregulated. And in the what we call a heat map here, you see these colors where you see red. It means that the cells were making a lot of that RNA molecule, which may or may not be translated into protein, but the cell was thinking, I need to make a lot of this particular molecule. And where you see blue, it means that those cells were downregulated compared to a normal resting state. So they were specifically suppressed. So the cell didn't want to make any more of those transcripts and ultimately those proteins. So this is what the analysis can look like. And also with Illumina, we now have taken possession of RNA sequence from a large percentage of the children on whom we also have the DNA sequence. And this is going to allow a very powerful analysis of understanding what's really happening in the body during the acute inflammation of Kawasaki disease. And all through this, I just have to keep on repeating, thank you, thank you, thank you to all of our families who initially in the emergency room agreed to the extra 2 teaspoons of blood when their child was having blood drawn for clinical reasons anyway, or having their IV started. Thank you for trusting us and thank you for participating. And equally, when you come back to clinic and you agree to participate in our genetic study, thank you. It's the only way we can do this is through this partnership. So now we're moving on to a brand new platform. We're so excited about this. This is really a very, very new story in molecular biology. And I'm going to explain what this is. We can take from the blood the liquid portion of the blood called the plasma and remove the cells. So we're not interested in asking what those cells are making. There are lots of cells, all the white blood cells and red blood cells circulating in our blood. We're going to remove those, and we're just going to look at what's left, and we're going to look at the RNA that's left. So this is cell-free. It's not within a cell. It's floating in the blood. And it turns out that when you have injury to your heart, let's say, or to your liver, when those cells break down, all those little bits and pieces from the exploded dying cell eventually make their way into your circulation. And in the circulation, there will be these little bits of RNA floating around that are a signal that they came from a dead and dying cell, or maybe a cell that was rapidly turning over. It was very activated and died as part of that process. And we can then take those RNA sequences and determine what they were. And this is work that we're currently doing with a very talented group at Cornell University, Ewan DeVlamick, and his lab there with Connor Loy, a graduate student there. And what they do is they sequence the plasma that we send to them from our Kawasaki disease patients. And this might be comparing before and after treatment to try to look at the effects of different treatment. Or it could be in children who have developed or not developed the complication of coronary aneurysms. And once they determine the sequence, they literally look it up in a dictionary. And the dictionary is called Tabula Sapiens. And they are able to map the sequence back to the cell where it originated and therefore the tissue of origin. And what this tells us about is tissue injury. And we know already from the beginning of this collaboration that there's some Kawasaki patients who have a big signal of injury to their liver. And there are other Kawasaki disease patients who have a signal of injury to other organs. And Hao Wang's going to be talking more about that as we go on. Now, this is not a simple analysis. This takes bioinformaticians who are a new breed of person to really understand this complicated mapping, but it's an exciting new horizon. And I want to introduce our bioinformatic team. But when I went to medical school, I don't think this word had been invented. And I really think of these people as the new superheroes of biomedical research, because these are people who not only have a computer science and computer programming background, they also have to have some knowledge of biology, a deep knowledge of statistics, and they bring together all these different disciplines and make a hybrid capability where they can take this very, very complex data and search it and understand the meaning that is locked within these complex data sets. So a shout out to Jihoon Kim, who is now at Yale, Hao Wang here at UCSD, and Mersini Kafaro at Imperial College. And there will be an expanded group as we continue to collaborate with others, but an exciting time for us. And finally, just a shout out to our fabulous group here at the Kawasaki Disease Research Center. It's really a privilege to be the director of the center and work with this talented group of people. So I'm now going to stop sharing and turn my screen over to Hao Wang.
Thank you, Dr. Burns. Start sharing. Good morning, everyone. Thank you for joining us today. My name is Hao Wang. Today, I would like to talk about the subgroups of Kawasaki disease and why it is important to understand these subgroups of Kawasaki disease, both in the research and clinical context. As you may already know, that Kawasaki disease is named after the Japanese pediatrician, Dr. Kawasaki. He reported 50 Japanese children who presented with a cluster of similar clinical signs in 1967, which set really the cornerstone for the current diagnostic criteria for this disease. However, if we take a closer look at the physical signs that Dr. Kawasaki's patients presented initially, as shown in this table, you can actually see that except for fever, none of the other clinical signs were found in all patients. Today, I think most of you are aware that your child may not have had all the Kawasaki signs, but what this really tells us is that the clinical presentation of Kawasaki disease has always been different among the patients, even among such a small group of children with the same ethnic background and from a small geographic region. Over the past half a century, it has also been observed that the different patients have different responses to IVIG treatment, different risks of heart complications, namely the coronary artery aneurysms, and also different long-term outcomes from this disease. So all of this really makes us wonder, is Kawasaki disease really just one disease, or is it actually a disease with different subtypes or subgroups? So to answer this question, we thought about the AI based on the clinical data collected from our patients at the time when they were diagnosed with Kawasaki disease, such as their age, their first set of lab results, the readings from their first heart scan or echocardiogram. Will the AI algorithm be smart enough to figure out different patterns and cluster our patients into subgroups? With this in mind, we retrieved the data from over 1,000 KD patients across the past 2 decades, which may also include your child as well. And we put them into the computer, and the AI clustering algorithms did identify 4 very different subgroups of KD. So in the next couple of slides, I would like to just show you 2 examples of these clinical differences among the subgroups of Kawasaki disease patients that we identified. The first example is about the response to IVIG treatment. I think you've likely already heard about the phrase IVIG resistance from our Kawasaki disease doctors before, which means the presence of fever 36 hours after the first dose of IVIG treatment. Clinically, this just means that the patient requires additional treatment. But if we look at the left bar, the bar plot on the left side, we can actually see that the risk is not the same actually among the 4 subgroups of Kawasaki disease. We can see that the risk of IVIG resistance is the highest in the first subgroup, named the liver subgroup, because of significantly higher biomarker levels of liver injury in their initial blood tests. On the right-hand side, you can actually see the risk is the lowest in the 4th subgroup, named the young group, because they had Kawasaki disease at a much younger age. The second example is about the risk of developing coronary artery aneurysm, which is actually something that we're most concerned about in the long term. We observed a different trend of the risk across the subgroups, with the lowest risk in the liver group subgroup and the highest in the young subgroup. And also, as Dr. Burns has just explained, we also looked into the molecules actually from the blood samples of our patients to further support the existence of this subgroup. So what we looked into are the 2 types of molecules called the proteins and the cell-free RNA molecules released from the injured cells due to this disease. Not surprisingly, we found that the quantity of many of these 2 types of molecules were significantly different in the blood samples of our patients among different subgroups. So what this really suggests is that there are indeed subgroups of Kawasaki disease with different changes in the body. So based on these results, we concluded that rather than a single disease, Kawasaki disease is more likely a disease with multiple subgroups. And then it comes to the next question: why does it matter to know these subgroups? Because currently the first line treatment for Kawasaki disease is still IVIG, and we're still doing heart scans or echocardiograms on all patients. Well, first of all, it is important to Kawasaki disease researchers, as there are more and more studies suggesting that Kawasaki disease is actually caused by a combined effect from environmental exposure and as well as the genes of the patient. Therefore, different Kawasaki disease subgroups could be very likely caused by different environmental triggers as well as different genetic susceptibilities. It will be therefore important for us not to mix these subgroups when we study KD to avoid comparing apples with oranges. And secondly, we also observed different proportions of subgroups in different racial and ethnic groups. Therefore, it is highly likely that there is a similar difference in subgroup proportions across the world. There could also be other KD subgroups that this study didn't uncovered but can be found somewhere else in the world. So this calls for a global collaboration to cover as many subpopulations as possible in order to really understand this disease. And finally, in terms of clinical application, understanding Kawasaki disease subgroups will help with individualized treatment plans. And I think this is something in my mind, but it may well happen in the next decade, that within the first 2 days after a KD patient is admitted, we will be able to input the clinical data of this patient to the computer, and the AI algorithms will be able to tell us not only which subgroup of Kawasaki disease this patient likely has, but also to predict this patient's personal risk of IVIG treatment resistance and of developing coronary artery aneurysms. And this will further assist the physicians to make stratified management plans and that best fits the specific needs of this specific patient. Well, I think all this may sound like fictional at this moment, but we will continue this endeavor to harness the power of AI and to create such a future that we're looking forward to. With all this, I thank you very much for your attention. I'm happy to take any questions later.
Great. Thank you, Hao. So we're going to move on now to our Q&A session. And people have put questions into the Q&A place where you've typed them in. So please keep on going, because we're here to answer your questions, and happy to do that. And I think Audrey has been monitoring the Q&A and is going to distribute questions and call on various people to answer them.
Yes. Hello, everybody. Thank you for joining us. I've been amazed at the globe of folks that are joining us from all around the globe. So thank you this evening, whatever time it is in your time zone. I'm going to go ahead, and I want to start with the question for Amelia. How will this be available and distributed to folks for them to post and to be able to spread the word or watch later with a beverage of choice? So Amelia, how is this going to be distributed later?
The webinar is being recorded, and we'll have a link available next week, and we'll be sending out the link to those who are on our mailing list. So if you're not on our mailing list, email kdresearch@ucsd.edu and just request to be added to our mailing list.
Okay, so kdresearch@ucsd.edu. Also, this session is being put on with the help from the Kawasaki Disease Foundation, and I'm sure we can work with them to see if we can also post it on the KD Foundation website as well. If any of you have connections with a parent foundation outside of the US, also email us, and we can hopefully help you also post that on your website for your parents. So let's get into some detailed questions here for the next 30 minutes that we have together for the Q&A. And I think there's a number of questions that I'll be passing around, and specifically we're going to start with Dr. Burns. So it's a question about ethnic and racial predisposition to Kawasaki disease. Is it rare for African-American children to be diagnosed with KD? My daughter was diagnosed at the age of 6. So in terms of predisposition.
So it's absolutely the case that there is a hierarchy of genetic predisposition, which must mean that there are differences in the complex genetic pattern that makes children susceptible to Kawasaki disease, depending on your race and ethnicity. And what we understand right now, although there are two pieces to this, right? There's the genetics and there's the exposure to whatever the trigger or triggers are. In Japan, that's the country of highest incidence in the world that we're aware of. We don't have good data from the Philippines. We don't have good data from China. So this is just based on available information. We don't have very much data from Africa, for example. But we know here in the United States, the population that is the highest risk is across all of our Asian groups. And here in San Diego, the Filipino and Vietnamese populations are highly susceptible, and those are our largest populations, but we also disproportionately see Japanese, Chinese, Korean children here in San Diego. We have a small African-American population, but it's very clear from research that's been done in Atlanta and Washington, D.C. and Detroit that African-American children are at higher risk of getting Kawasaki disease than European descent children and Hispanic children. So it is not unexpected that your child was diagnosed with Kawasaki disease. I think there's some special challenges about diagnosing Kawasaki disease in dark-skinned patients, in that sometimes the rash can be subtle and more difficult to see. But certainly we need to have an increased awareness and a higher index of suspicion for our African-American children than European descent and Hispanic, because we clearly have shown with the epidemiologic data that they are more susceptible to this. They are more likely to have a genetic pattern that makes them likely to get Kawasaki disease as compared to Hispanics and European descent, but less likely than our Asian patients. So that's sort of the distribution of likelihood across different races and ethnicities.
Thank you. So there are also several questions about triggers of KD. There's a question about several questions about children that have been ill before having their Kawasaki disease, whether with a strep infection or with RSV. So just questions about if those can be triggers, and if there's any defect in the immune system in children with Kawasaki disease.
I'd be happy to answer that, and maybe you want to chime in too, Audrey. So first, let me say that in terms of the immune system, these children, by and large, were normal up until the time they had their Kawasaki disease. They received vaccines and had normal responses. They had the normal childhood viral illnesses. There was nothing special about their handling of challenges to the immune system before they had Kawasaki disease, and that appears to be the case afterwards as well. Now, in terms of long-term outcomes, we encourage everybody over the age of 15 to join our adult KD study, and you'll be hearing more about that in the second half of the presentation, because really there's been no study that can absolutely answer the question about long-term outcomes in our Kawasaki disease patient. And these kinds of studies require huge numbers of patients because, of course, individuals may develop certain problems as they go on in life, but that doesn't mean it was linked to their Kawasaki disease. It's just true and unrelated. So please do sign up for our studies.
Dr. Burns, I believe you're muted.
Whoops, I got muted, sorry. In terms of previous infections, there is a wonderful new story, or at least a new analysis of the Japanese data coming out from our climate team that Charles Copeland will be talking about a little bit later, but also is in a publication that's in revision and hopefully will be out soon, that really makes a compelling case for person-to-person spread being part of the story of Kawasaki disease, but then a larger environmental exposure also being a cofactor in who gets sick. So I would say RSV and strep are not part of the picture of susceptibility to Kawasaki disease for the following reason. Kawasaki disease was a new disease in Japan after World War II. It, as best we can tell from all the historical investigations that have been done, did not exist before World War II. So strep and RSV are viruses that have been around for as long as we've had clinical records. So we don't think that those are specific triggers for this. It's something new. And again, just to emphasize, the paradigm for what causes Kawasaki disease is not going to be a story that matches anything simple that we know about. It really is its own story. And we don't have all the pieces to that story yet. This is the 15th Kawasaki Disease Parent Symposium. Maybe by the 20th symposium, we're going to have nailed it. But we don't want to try to cram the Kawasaki etiology story into something that we know, because based on what we absolutely know now, it doesn't fit any easy disease category. So RSV, any other viral infection that we know about, or bacterial infections like strep, at this point in time are not cofactors in setting your child up for having Kawasaki disease. They're simply common things that happen commonly to children and could be temporally associated with the onset of Kawasaki disease, but that's true and unrelated.
And I'll just follow up with that because there's some questions also in the Q&A about, being exposed to influenza or having mono, other diseases like that. We know that our children that are diagnosed with Kawasaki disease have a co-infection rate of having an infectious issue at the same time in around 15% of our patients at least. And it's much higher around the globe in different parts. I was just in India and people are having, they have dengue and other illnesses and tuberculosis along with their KD. Those are going to be co-infections rather than the cause. The other thing that's also come up a lot here in the Q&A is about relationship with vaccines. And gratefully, as Dr. Burns said, these children with Kawasaki disease have normal immune systems, continue to have normal immune systems after, and vaccines have not been found to be a trigger for Kawasaki disease. And as infectious disease specialists, we would encourage you to get your children vaccinated for any vaccines that are available in your country. I'm going to move on to a question about the what we've been sharing so far. Dr. Burns shared the handout that's been made for peeling. We also have other handouts that our group has developed. And the question came up about how those are being shared and circulated. I will say that Dr. Burns and I travel quite a bit, and I'm leaving in a few days to go to the American Heart Association, and we'll be sharing there with the World Group of Pediatric Cardiologists a lot of the forms that have been created. These are not proprietary in any way. We're welcome to share those with you and your group, and are hoping that this sort of information becomes sort of the norm. So if any of you again have a parent group and would like a copy of what we've developed or anything else, please let us know. Let's see, we've got some questions related to the use of steroids and why those our team doesn't use as often. And I will just say that as I answered briefly in the Q&A, this is very center specific. And while our team tends to use infliximab more specifically for children with either coronary artery aneurysms or resistance to IVIG, groups around the globe, including many centers here in the US, will reach for steroids. There has not yet been a trial that has had a head-to-head comparison of children being treated with adjunctive therapy, additional therapy like infliximab or steroids for coronary artery aneurysms. The trial is written. If anyone there knows someone who wants to fund it, reach out to our team. We would be happy to launch that trial. We have tried incessantly, I would say for the last 5 years, if not longer. So we would love to get funded and to do that and to answer that question as to what's the best treatment for coronary artery aneurysms. But we have the patients, just not the cash. But yes, it's very center specific. And the drugs that we have discussed so far and others that will be mentioned today really come from the work and science that's been done in our center and others to understand the underlying immune response that happens in children with Kawasaki disease, and frankly, how to turn off that fire that's happening. Okay, so let's move on to a question about coronary artery involvement for Dr. Drummer as our resident cardiologist here today. And we're so happy to have her on our team. I can't tell you how excited as a Peds ID doc I am to Dr. Drummer. So thank you, Dr. Drummer. There's a question about my son is 10 now, and he had KD at 4 months and 5 years of age. The first time he got a giant coronary artery aneurysm, that started to shrink, but then he got a recurrence of his KD at the age of 5. I was able to help the doctors catch it quickly the second time. His aneurysms dilated again, but not as large as they once were. So he's beginning to play basketball. Some doctors are advising against it. Can you speak to aneurysms and sports activities? And is there anything that we can do with helping his aneurysms get smaller?
Sure. Those are great questions. I think you said that the child is 10 or 11 or something of that age, maybe.
He's now 10, yeah.
10, okay. So the way that we follow our patients who still have giant aneurysms or moderate aneurysms, so I don't know what a Z-score is, but the sports limitations and recommendations really have to do with the medications that people are on. So if your son is requiring systemic anticoagulation like heparin or Coumadin or rivaroxaban or Pixaban or one of those medicines, that is kind of a higher risk for sports-related injuries or joint trauma or head trauma or things like that. If the patients are on antiplatelet therapies like aspirin and or Plavix, those are much lesser concerns and risks. What we generally do is we advise patients who are on systemic anticoagulation to probably avoid sports that risk bodily collision and direct contact. So we don't really want them out there playing football and sports where collisions are frequent, because if you're on those sorts of blood thinners, then you're at risk of getting traumatic bleeding and things like that. However, there are some patients who play sports anyways, regardless of the recommendation. Baseball is not necessarily a contact sport. You can obviously get hit by bats and balls and things like that, but that's not the point of the game. So if our patients are playing a sport and they understand the risk and it's not a collision sport, as long as their exercise testing is normal. So exercise testing is really important when kids still have aneurysms. We use bicycle stress testing in our patients because most kids can ride a bicycle by the time they're 7 or 8. And we do stress echocardiograms on all of these patients to make sure that when they are exercising and exerting themselves, that they have good heart blood flow and heart function. So having a normal stress echo would be really important before you allow them to play. The other medications we use are statins. So we use atorvastatin or Lipitor in our patients that have aneurysms or have abnormal coronaries because we know that it helps the lining of the cells called the endothelial cells be healthier. So we think that that's a good medication. I can't tell you that that's going to help them remodel, but I can tell you that it helps them function more normally. So we use statins and the blood thinner platelet medications in giant aneurysms. And a lot of our patients with giant aneurysms are also on a beta blocker. A beta blocker can kind of impact your ability to exercise at higher levels because it blunts your heart rate. But we think it helps the myocardial, the heart muscle oxygen demand, kind of balance it out with flow and things like that. So medical therapy, stress echo testing, if it's normal, and no collision sports is what we tend to recommend.
Thank you, Dr. Drummer.
Mm-hmm.
So there was an important question about if any of these recommendations that we're discussing this morning will be in the next iteration of the American Heart Association scientific statement. And I'm happy to say that I was the committee chair for that group for the last few years. And although I'm not the committee chair anymore, I'm actually on the writing committee for the updated scientific statement for Kawasaki disease. We are busily working on that. It will hopefully be published before or by next summer, before the International KD Symposium, where we hope you'll all join us in Montreal, Canada, so that we can share those that new information. But yes, the recommendation for intensifying therapy for Kawasaki disease that Dr. Burns discussed was actually part of the 2017 statement. And it will be further emphasized with information about the new treatments that have been studied since 2017 in the upcoming statement that will be published next year. So let's see, there are quite a few questions. This is for Dr. Burns and for Hao about the liver group, the liver subgroup that's been discussed. In terms of long-term implications, if there's any long-term follow-up that needs to be done specifically for that group, or any tests that need to be conducted on the child's liver in that subgroup of patients.
So, easy answer, no. The liver, in terms of an organ that can be damaged, is one that's very resilient and can really pick up the slack. And there's no evidence that there's ongoing or permanent scarring or abnormalities that have functional significance for the long term. So the good news is no. I think the importance of Dr. Wang having identified these subgroups is, gee, are these kids showing a lot of liver damage during the acute disease because of their genetics, or because of the trigger to which they were exposed, or some combination of those two? And so having this awareness that there are subgroups, and we need to, as Dr. Wang said, not be lumping everybody together in our analyses, it is, for me, a really profound insight, and is really going to change the way we analyze the big data that we're generating and that Dr. Wang is part of analyzing. So no concerns about liver injury going forward.
And in terms of any other organs besides the liver, there are questions about the urinary system being involved, which we don't attribute actually for Kawasaki disease. There's also questions in the Q&A session about behavioral issues after Kawasaki disease, which also behavioral and developmental issues have not been associated with Kawasaki disease. The hard part, of course, is that KD happens during a rapidly developing time for our children. And there may be other diagnoses or other issues that your child was going to develop regardless of their Kawasaki disease that then emerge. But in terms of neurological or like the kidneys being involved or the brain being involved, gratefully that has not been associated with Kawasaki disease.
If I could add a word there, hospitalization for a 2-year-old or a 3-year-old is a traumatic event. And it doesn't matter whether you're being hospitalized for a broken toe or for Kawasaki disease or whatever. So we see a lot of behavioral changes and disturbances and issues coming up when we see the patients back in clinic. And this is just a tough age to have something done to you that you really didn't like. And so there's a lot of anger issues, a lot of acting out.
Fue algo difícil que les pasó a ellos, ¿verdad? Lo de la enfermedad de Kawasaki. Perdón, ya apagó su micrófono. No sé.
Sorry, somehow I got
Ay, perdón, disculpe, apagué mi micrófono.
So just keep that in mind, that your child may have real anger with you about why did you let those mean people do that to me? You were sitting right there and you let them poke me and do mean things. So it's a tough age. And we often recommend counseling for our families where they're struggling with this. It's not Kawasaki disease. It's really just the age and trauma from hospitalization.
So there are questions also, Dr. Burns, you can answer about the genetics of Kawasaki disease in regards to twins being at higher risk, at siblings being at higher risk for Kawasaki disease, especially younger siblings, if they could get KD.
So if your child has older siblings in the family at the time that they develop their Kawasaki disease, you can rest assured that those older children do not have the complete genetic pattern and will never get Kawasaki disease. Because if they had the right genetic pattern, whatever that exposure is, whatever your child breathed in, everybody's breathing the same air. And so everybody who had the right genetic pattern to get Kawasaki disease would be sick at the same time. So that applies to twins. And with twins, there are two kinds of twins. They're what we call monochorionic twins, which are identical twins. And then there are twins that actually are just like having a sibling. It can be a brother and a sister, but they just happen to be living in the womb at the same time and be born at the same time. So those two children are just as genetically different as siblings are, brothers and sisters. They might be sister and sister or brother and brother, but the point is that they're what we call fraternal twins. They don't share identical genetic information. When we see a family where there are identical twins, meaning that at least in a large sense, they share entirely their genetic pattern, we will actually do some laboratory studies looking for inflammation on the well twin at the time that we're taking care of the sick twin. And if it has happened that those laboratory studies actually show inflammation that was not suspected because there was no fever, and we've actually then done a heart scan and echocardiogram and found some subtle abnormalities. So that applies to identical twins, but not to fraternal twins.
Great, thank you. So, Dr. Doomer, there's some questions about regression of the coronary arteries. And so one of the questions has to do with the Z-score size. I think you addressed this a bit. One parent wrote about their child having a Z-score of 2 and wondering if that would get better. But I'm wondering if you could just speak to the general concept of regression for patients.
Sure. So a Z-score of +2 is just at the upper ends of normal. So if it's +2.2, then that's just above normal. And so that's just considered mild dilation. That often gets better, sometimes even gets better before the children leave the hospital, but that's very, very, very mild dilation. So that often regresses back to normal. Actually, we risk stratify the patients based on what their worst Z-score was. And then this is all published kind of categories of patients, American Heart Association risk levels. And so if you start out with a giant aneurysm, which is generally a Z-score above +10, like we talked about, and it slowly gets better and you kind of end with a Z-score of +5, that is some regression, but the vessel is still not normal. So that risk category is the highest risk level, which is 5, because you had a giant aneurysm, but now it has regressed down to kind of the small to moderate range. And so those risk categories are 5-point, and then it's 1, 2, 3, 4 based on how much you have regression. So any size vessel can regress, whether it's a Z-score of +2.2 or +10, but the likelihood of regression is lesser the larger your vessel is at its worst dimension. So there's, I don't know, Jane and Dr. Tremoulet and Dr. Burns know this data better than me, but let's just say if you have a giant aneurysm, there's, you know, only a 50% chance that it's going to regress to a smaller aneurysm. But if you have a small aneurysm, there's like a high likelihood it's going to regress to normal. I don't know, 80%. I'm making it up. But any vessel can have some regression, and some vessels can have total regression. And we don't quite understand why that is yet. How's that, Dr. Burns and Tremoulet? Jump in.
So the International KD registry that's run by Brian McCrindle and Najib Dada in Toronto and Montreal, that is a registry from which we're trying to learn about exactly answers to this kind of question. It's not a perfect way to study it, but it's kind of the best we have. And when they did a study, I mean, there are giant aneurysms, and then they're really giant aneurysms. So as you get a Z-score above 10 and you get up to 20 or you get up to 30, those really, really large aneurysms, and particularly if they're on both sides of the heart, so involve both the right coronary artery and the left coronary artery, those are much more likely to persist and to create a lifelong risk. Whereas the smaller giant aneurysms have more of a capacity, it appears, to remodel. And it just has to do with injury to the vessel that we're still trying to understand and categorize. And I'm hoping that maybe cell-free RNA that we talked about is going to be a way to look at tissue injury in these people and maybe give us a handle on predicting who's more likely to remodel. We'll have to see.
So for Dr. Burns, there's a question about the discoloration of the nails and if that persists, or if there's any signs other than the arteries of the heart that persist.
So these are two separate questions about the nails. And then what was the other part?
So mostly focusing on the nails, but there's several, as I'm going through here, the Q&A, there's other questions also about anything other than the coronary artery aneurysms persisting in patient with Kawasaki disease.
So I'll let Dr. Doomer answer the other artery story. So the nails are really interesting because they grow out and they're a sign that they're sort of a history lesson of what happened when the nail was being formed back here, and then it grows out and we can see it. There's an interesting orange discoloration of the nails that's been well described by dermatologists. I'm not aware that it persists. It's more something that happens around the acute and subacute phase. But as far as my experience has been, those nails a year later look normal. So if the nails are still discolored, I would go to a dermatologist and ask them what their thoughts are.
And Dr. Doomer, can you speak to other aneurysms besides the ones of the coronary arteries? Are there aneurysms in any other places or anything else at risk?
Sure. I mean, just thinking about the heart itself, I mean, there are other places where aneurysms can occur, like in the axilla. So in the underarms, there's an artery that can be dilated just like the coronary vessels. Also, same is true for vessels in the groin area. They can have aneurysms as well. It's interesting. We don't necessarily scan patients from head to toe, but kind of in our exams, we're feeling their underarms and palpating kind of the regions where you might find them. They're pretty rare. I don't know, in my experience, they're pretty rare. And I'm not sure about the persistence of them if they occur, to be honest with you. In my experience, I haven't had patients with those significant aneurysms. There are other heart findings that can suggest inflammation. So when we look at the heart, we're also looking at the valves. So you can have valve leaking of the mitral valve that can be associated with the acute inflammation that usually does not persist. It usually goes away as soon as the inflammation goes away. and you can get aortic dilation. So there is about 10% of the Kawasaki patients who also have the big aorta is the candy cane vessel that comes out and brings blood to the body. And that aorta can be dilated, that it can be kind of first noticed in that acute phase. Generally speaking, that kind of gets better over time as the patient grows. So it's more about a mismatch, but felt to be potentially related to Kawasaki disease, but those things get better with time. And I don't know, I mean, Dr. Burns and Dr. Tremoulet talk about the axilla and the iliac.
So for the peripheral aneurysms, certainly in our adult Kawasaki disease group, we've had patients present with pain syndromes. We call that claudication when they use their arm, because they have restricted blood flow coming from the aneurysm in their brachial artery. That's the artery that supplies the blood. So you can imagine that, you know, if your heart isn't getting enough blood flow, the heart muscle, then you develop angina, which is a pain in your chest. If your arm isn't getting enough blood flow because of the aneurysm, you develop pain in that arm. And we've actually, in some of our adults, had to surgically resect the aneurysm and put in a graft to restore flow. Fortunately, because these are pretty accessible surgically, it's a pretty straightforward procedure with a skilled vascular surgeon. So it can actually be fixed. It's a little trickier with the iliac arteries and femoral arteries to repair those when there are symptoms. And these are mostly patients in their 30s, so young adults who develop these kind of symptoms. So they're important, and they certainly can cause long-term disability and problems, but they're surgically easier to fix than the coronary issues.
Thank you. So there's also a question about IVIG and hemolytic anemia, which I think is important for us to touch upon this, because I don't think we're going much into treatments during this, because we've covered this in years past. But there's a question: my child with blood type AB had hemolytic anemia following IVIG, requiring a blood transfusion, and whether we see this at Rady Children's, and also in terms of the follow-up. Dr. Burns, do you want to speak about kid care? Because I don't think we're going to get to kid care today, but I think it's important for all of our families to know the work that's been done and the recommendations.
Sure. So the team here ran a national trial of 30 different sites to try to learn in the comparison between giving a second IVIG infusion or giving infliximab for children who had persistent fever, what we call IVIG resistance. Which one of those treatments worked better? Now, we didn't compare steroids, which is a third option, but you can only compare really in a trial two different things and still have enough sample size, enough patients to enroll. So we chose to just compare those two things. And what we saw in the patients who received, so infliximab, came out better, looking better, just with respect to ease of treatment and shortened hospitalization and less fever and more durable treatment, not requiring more treatment. The IVIG people who got the second IVIG, we had a lot of hemolytic anemia there. So your child who has the AB blood type, the hemolytic anemia was caused by the IVIG. It's not your child's body that did that. It's the treatment that the child received. Now, your child needed to get the treatment, but it's an unfortunate consequence. And why is this happening? It's happening because the IVIG that's collected from something like 10,000 adult plasma donors and then purified to get this white powder that is then reconstituted, that contains antibodies to blood group A and to blood group B. And the more people, the more donors that Big Pharma uses who have blood type O, those are people who essentially have naked cells, naked red blood cells. They don't have A or B. and they make antibodies to A and B that they may get exposed to from the diet or other sources. And so unfortunately, the commercial products that are available now with IVIG, and some are worse, some brands are worse than others, contain a fair amount of anti-A and anti-B antibody, and they will cause some level of hemolytic anemia in all patients with blood type A or B, or in your child's case, AB. And it's just an unfortunate consequence. There would be things that Big Pharma could do to remove those antibodies, but that's not being done.
Thank you, Dr. Burns. So there are a number of questions in the Q&A that have to do with long-term follow-up and testing that we recommend. I tell you to hang on tight because we're going to take a 15-minute break, and we'll be back at 10:45, and I will be discussing and hopefully answering those very questions in terms of the transition of care of our children and follow-up and long-term follow-up for kids depending on their Z-scores that Dr. Duber talked about. So it all really hinges on the maximum size of the coronary arteries of your child is really what helps us determine what to do long-term. So with that, we're going to take a 15-minute pause. We're all going to get back on at 10:45 Pacific Standard Time, and we'll be talking about transition of care at that point. So thank you, everybody. See you back in 15. here at Rady Children's Hospital in San Diego and the University of California, San Diego. And you've had the pleasure of hearing from our team for the first half. Quite a few of you messaged with concerns of not being able to be on. No worries, it's being recorded, and you should be receiving a copy of it this coming week. If you're not on our mailing system, I did just post that, and you can email us at kdresearch@ucsd.edu to go ahead and get a copy. So with that, what I'd like to go ahead and talk about is a little bit about the transition of care for our Kawasaki disease patients, and to hopefully start to answer some of the questions about the long-term care of KD patients that's been brought up by several of you in the Q&A. Hopefully everybody can hear me. So we have the distinct pleasure as pediatricians to watch our children grow up. And as parents, you know that your baby is not always going to stay a little baby, although many of us would love that. I have a 13 and 16-year-old myself, and they grow up and become independent young women. But it's important also with that growing up to understand what's going to happen with our children that have had Kawasaki disease. How often should they be followed? What studies should be done? What's in the works for them for the future after having had Kawasaki disease? And I hope that between what I discussed now and what Angie Rodriguez will talk about with the Adult KD Collaborative Study, we'll start to answer some of those questions. So Dr. Drummer did a lovely job at already discussing this about the Z-score and what that is, but I think it's important that we cover it just once more, because the question of what is going to happen long-term to my child who's had KD hinges on my question, which is, what was your child's Z-max? What was the maximal size of their coronary arteries? So here is what happens when an echo is done. The internal diameter of that coronary artery is measured. But as you know, our children grow up. So if your child is 6 months old when they have their KD and you get an echo, that internal diameter of that coronary artery is going to change over time. So when we see that child back, if we have to see them back when they're 5 or 10 or 15, we have to be able to compare over time what has happened to that coronary artery. And it's not just the absolute measurement, but in fact, it's the Z-score. So the Z-max is the maximal internal diameter of the coronary artery adjusted for body surface area. And body surface area is collected or is calculated based on height and weight. So that's why it's so important when your child gets diagnosed with Kawasaki disease that their height and weight has been measured correctly, because the majority of the medical decisions will be made based on that information and calculating that Z-max. And as Dr. Drummer showed, here is a curve showing where coronary artery dilation. So if your Z-score is more than 2, between 2 and 2.5, it's a dilation. Above 2.5 by the American Heart Association, it is considered an aneurysm. So it's important for you to know, and for your children as they grow up, to get to understand what their Z-max was, because that actually drives all further treatment and long-term follow-up. So one of the things that our team has also been trying to do, and Dr. Burns has already shared some of these forms that we're working on, is here's a form that we are now giving to all of our patients. This was put together by one of our visiting students from Japan recently. And we want our patients to understand when they're in our clinic, as they're growing up, especially when they leave our clinic, how old they were. So we ask them about, they can fill in their diagnosis, what their symptoms were. So I give this handout to our children that are graduating from our clinic. I go through their history and I have them circle all the signs that they had with KD. I have them list their Z-score so that they understand what that is. We go through the Z-score graph to understand here, as you see in this little table, whether they had a normal or a dilated or an aneurysmal coronary artery. And also to empower them with some information. So here on the left, you know, what is their current height and weight? What's their blood pressure that day? What does their cholesterol panel show? And then on the right here, what medications are they on for KD? And why did I have Kawasaki disease? Some questions that we've already discussed about genetic patterns, about triggers. So we think it's very important for our children as they grow up to really understand their diagnosis and to understand if they need to have any long-term follow-up. And this helps us empower them and to be able to have them be independent and understand their illness. So now I'm going to go through a little bit here about the testing. I'm going to spend a little bit of time here on this slide here, because what is the testing and follow-up for KD patients? It's based on your maximal Z-score. So here, if your Z-score was less than 2.5, so you never had coronary artery abnormality, or it was only a transient dilation, really the testing, the long-term testing there is really not much. These children will come in after they've been diagnosed with KD, come into the clinic, they'll have an echo that gets done at that time at the 2-week visit. We'll see them back at a year and have an echo done. But really long-term, whether they're not going to need a CAT scan, they're not going to need any long-term exercise, stress echo to be done where they're on a bicycle. And these kids are discharged from the clinic and really do not need any long-term follow-up. Now, many of you have asked in the Q&A about how long to be followed up. Again, that's very center dependent. If you're here in San Diego, you know we love seeing you every few years. We actually don't discharge anybody usually before they reach the age of 15. But in the guidelines for the American Heart Association, it's actually okay to be discharged from care earlier than that. And many centers are seeing their kids back at 2 weeks and then at the year, and then discharging them from their care at that point if they've always had normal coronary arteries. But we love to keep you around, and we love to be able to give you more information about what we've learned about Kawasaki disease. So after that 1-year visit, we generally see our patients every 5 years until they reach 15 years of age. What about the kids with the history or presence of small aneurysms with Z-maxes of 2.5 to less than 5? Again, we'll see those children at 2 weeks, we'll see them at a year, but then how often we see them after that really depends on what happened with those coronary arteries, how big they got, how long they stayed abnormal. So maybe it happened quickly and it disappeared quickly, but generally for these patients will at some point during their care have a calcium score that gets done, the CT angiogram that gets done to look at calcium depositing in the coronary arteries in the late teenage years. And that helps us to really understand if there's any long-term follow-up is needed. And the reason that we know that is actually thanks to the Gordon and Marilyn Macklin Foundation, who have been supporting our work with the Adult KD Collaborative that you'll hear from Angie in just a few minutes. But we learned from that initial part of our Adult KD Collaborative that children in this group, with looking at their calcium score, we can figure out if they need any long-term follow-up. So some of those children in that group will also get a stress echo where we have them come in their exercise clothing. After they're about, at least 8 to 10 years of age, they can get on a bike, they can pedal a bike, and we're going to have them pedal really hard, get to a maximum, good heart rate, and then get an echocardiogram to see how the heart responds under stress. That's what a stress echo is. So in terms of long-term follow-up, this group, this is controversial, but it really depends on the testing result that's done, on the CT calcium score and the stress echo that's done. Really depends on whether or not they need to be seen. Now, the group that's a little bit clearer are the ones that have a Z-max of greater than or equal to 5. And I got a number of questions about, we got questions in the Q&A about when that shows up. The majority of coronary artery abnormalities show up in the first 10 days of illness. And most kids that are going to have issues are going to have it on that initial echo when they're seen in the hospital, if not shortly thereafter. But if your child had a Z-max of greater than or equal to 5, which would then be categorized as moderate or giant aneurysms, then the testing, I think there's a lot more agreement on the testing, but there is a stress echo getting again on some form of equipment like a bicycle for the older kids to have a stress echo at regular intervals, and a CT angiogram may be done early. It may even be done soon after the initial diagnosis. But eventually it will also be done with calcium, because we've learned that calcium takes about a decade to deposit if it's going to happen in the coronary arteries. So again, this group is higher risk for long-term consequences. And so this is the group in which we refer them to an adult cardiologist for long-term follow-up, to be seen in the future. Maybe not so frequently, but these are the kids that are then being seen by an adult cardiologist. So one of the important things that I want to cover is transition of care. So while many of us are seeing these children as they grow up, and especially with those children that have a Z-score greater than 5 that will need some long-term follow-up, it's really important that you have to start to have a discussion with your local KD team about who is going to follow up your child, and to make sure that there is a process in place for that follow-up. So we wrote a statement for the American Heart Association just a couple of years ago about falling through the cracks, the current gap in the healthcare transition of patients with KD. And there is a process that that a center can go through in order to make sure that that transition of care is there. And I leave in a couple of days for the American Heart Association, and this is the topic that I'm going to be covering with pediatric and adult cardiologists from around the globe at AHA to make sure that this is happening around the globe. So what is needed for an effective transition of care? This is actually an area that's been studied by some experts, one of whom we were fortunate enough to have as part of our writing team. There's actually 6 core elements for transition of care from pediatric to adult healthcare. And so this starts at the age of about 12, where there needs to be really guidelines in place to develop a discussion, to share that transition with our family members. And then it goes through as the kids get older and really teaching them about what is involved in the transition of care, learning about their diagnosis of KD, understanding the medications that they're on, understanding the kinds of testing that's been done and the result of that testing. There's actually a step 3 here in terms of readiness. And this can be done through, we have actually developed a questionnaire that we have for kids that we start at the age of 12. If you have had an aneurysm at the age of 12, we start to do this annually for our patients so that we can assess their readiness and understanding their illness. And then really planning that transition, making sure that the center has an adult cardiologist with whom they are in contact so that you as a family knows who your child will be following up with, and empowering your child to know who that is. How do they make appointments? Where's your insurance card? All those things that that we want our kids to have to establish that independence. And the very last step, which is what everybody thinks about, but there's all these other steps, is the actual transition, and making sure that the documentation gets over to that adult cardiologist, that your child knows where their medical records are, that you've asked for a copy of those medical records from your pediatric hospital so that your child can have those with them. So here's a transition of care assessment that we do at Rady Children's Hospital, which other centers also have their own assessment that gets done. And it's really to assess what your child knows about Kawasaki disease. So one of the questions is, in your own words, how would you describe your medical condition to a medical provider? If they were to have a medical issue, and let's say that they are actually they have a giant aneurysm, they're on an anticoagulant, and they are in a car accident, how do they inform their emergency room physician about their illness? It asks questions about, is KD a genetic disorder? What medications are you taking for KD? So we want to make sure that they know what those medicines are. For their children with giant aneurysms, do they understand different kinds of chest pain? And when they're having heartburn versus when someone needs to call 911 for their children with giant aneurysms in case they are having chest pain due to decreased blood flow to their heart or having a heart attack. And then we also go over the use of drugs. Of course, we don't want our children to use drugs, but there's specific drugs, including things like smoking, and of course, methamphetamines and cocaine, that we certainly want children with a history of aneurysms with KD to avoid. And then just understanding the types of testing like we've just talked about with the coronary CT angiograms. So we have over the years, of course, developed relationships with our adult cardiologists. And I just want to call your attention to who we have on our team. We've been blessed to have Dr. Lori Daniels of the University of California, San Diego, who's been very involved in our adult care studies and who leads the cardiac intensive care unit at UCSD. We've also had Dr. John Gordon at the San Diego Cardiac Center, who many of you may know if you yourselves have had Kawasaki disease with aneurysms, who's been our follow-up. We're thrilled for his recent announcement of retirement coming up soon, but we want you to know that he's handing off the torch to Dr. Jikin Bhatt at the San Diego Cardiac Center, who we're very excited to have on board and to continue to provide excellent care for our young adults and adults with a history of Kawasaki disease and aneurysms as children. So with that, I'm going to go ahead and end by just saying that this and other topics are going to be extensively discussed in Montreal, Canada. If you've got your phones, take a picture of this. We're thrilled to have the 14th International KD Symposium, August 26th through 29th in 2024. We invite you all to be part of this. I have the pleasure of being a co-chair of this IKDS with Dr. Najib Dada, who's a pediatric cardiologist in Montreal, where the meeting will be hosted. And I do want to let you know that we are really working on increasing parent involvement in this meeting, KD patient involvement in this meeting. We're going to have a Meet the Expert session. There will be a session from KD parent associations from around the globe meeting with our KD experts, and we hope to have increased interaction. So we invite you to be part of this meeting. It will only be in person. It's just, unfortunately, the expenses it just does not allow us to have a hybrid meeting, unfortunately. But we do invite you to join us in person and to please let others know about that. So with that, I'm going to hand it over to Angie Rodriguez Verdin, who is our study coordinator for Adult KD Collaborative Study that's sponsored by the Gordon and Marilyn Macklin Foundation. And so I will hand that off to her. Thank you for your attention.
Hi, thank you so much, Audrey. So hi, yes, I'm Angie Rodriguez Verdin, and I am in charge of the adult KD study. Let me start sharing my screen really quick. Let's see. Okay, I believe you guys are able to see my screen now.
Yes, perfect.
Okay, perfect. So yeah, I am the adult research coordinator. So as Audrey was talking about, in the transition to care with most of our patients that we do see at Rady Children's at their exit visit, we aim to try to enroll them into the study. You know, it's obviously all voluntary. So some of our patients do not want to, that's totally fine, but we do encourage it. There are a lot of benefits to the study. Long-term wise, we're trying to understand the health outcomes and effects of KD into adulthood. Currently, we don't really have a strong stance or full understanding about what the long-term effects of KD can be. We do see that with our children whom have been treated for Kawasaki disease during their initial illness, they do a lot of the time, as was spoken before, remodel, and they are perfectly fine, don't have to be followed up by an adult cardiologist. But in some of our KD patients, that is not the case. And so it's really vital for us to understand what their long-term health will be for the patients whom fully recovered and those who require cardiac health follow-up afterwards. And so, well, let me see. This is all, I want to give a shout out as well to the Gordon and Marilyn Macklin Foundation. They are continuing to help lead our team of researchers towards a greater understanding about this disease, but also just help us contribute really to the world of Kawasaki disease and help us connect to those around the world that are also trying to research and understand, you know, what are the origins, how can we, in a sense, stop it or just learn better treatments as this team has been over the last, 15, 20 years. And then with our adult KD team, you may have seen some of these faces already, but Dr. Burns is our principal investigator. Dr. Gordon, and who's going to be now replaced by Dr. Jekin, is our adult cardiologist, as well as Lori B. Daniels. And then Andrew Kahn, Kirsten Drummer, and I as the research assistant. So many of you may be, what is the adult KD study? So it's a longitudinal questionnaire survey, really helping us learn more about the cardiovascular and general health of our individuals who experience KD in childhood. This is very vital for us because we do want to understand, are there going to be long-term complications later in life that are a result of you having had Kawasaki disease when you were a child? As I mentioned before, so far, if we have seen through our research in the past 10 years, that those who are fully remodeled don't really show any relapse of KD or any complications cardiac-wise from it. However, for our patients that did have cardiac complications and kind of have to be followed up, we do see that there, obviously for the follow-up, have to be research and continue to see an adult cardiologist. So as was mentioned before and kind of brought up in previous slides, these are outcomes after KD for patients who do have giant aneurysms. Now we do have kind of an understanding or are trying to better understand why some kids genetically are more susceptible to developing aneurysms than other children are. And so that is one part of our research center's focus, is to understand that a little bit better. And with the adult KD study, because it is a longitudinal study, we do ideally want to follow our patients for about 20 years after they first initially enroll in the study. And that really allows us to understand how the health trend in their life is, and then understand our patients whom either did have, giant aneurysms, small aneurysms, medium, or no aneurysms at all. And then also this study, our adult KD study, we've been able to collaborate with Tyler Gluckman's team at Providence Health in Oregon. And there in their system, they have about 373 adult patients who were coded as having Kawasaki disease or a suspicion of Kawasaki disease. And of those 300, they had about 36 that were coded as having coronary artery aneurysms. Now, the important and really vital thing about this is that if you aren't treated right away for Kawasaki disease, or you don't know and you go about your life without understanding or really ever knowing that you had KD, and if it's the case that you had coronary artery aneurysms during your illness, it is really important for you to get a calcium score test done to understand, if you have any calcium buildup, in your arteries, and if that is, what the treatment step is, whether you require medication or not, how much of a risk it is to your health. And it's really, really vital for you to have this health information. And we really try to collaborate and reach out to as many people as we can. The amazing thing about our study is that people can reach out to us via the email, primarily me, talking to us about, hey, I think I had KD when I was a kid, or I had it when I was a kid, and I want to learn more about it. What should I do? We receive a lot of these emails, or so I have in the past year that I've been part of this team. And it's really, really important for us to kind of be able to educate anyone who comes in our way about the importance of getting tests done, of learning about what KD is, the impacts of it on your health, the importance of seeing an adult cardiologist if you weren't treated for it initially. And thankfully, some of our patients who enrolled in our study, because they reached out to us, they weren't in the San Diego County, some of them are out of state, some of them are out of the country. They, after reaching out to us and then I contacting back, explaining everything, later on will reach out back to us a few months later, or maybe even a few weeks later, saying that they got the calcium score done and they found out that they had, a worrying amount of calcium built up in their arteries, and so are now on the path to dealing with that, getting medication, being followed up by an adult cardiologist, which in these terms is life-saving. But in the US, it's estimated that by 2030, 1 in every 1,600 adults will have had KD in childhood. Now, these are troubling stats. This is scary because that's a lot of people, but hopefully through the years, as we have been in the past 15, 20 years that Dr. Burns has been working on this in the team as well, our treatment and ability to detect it has improved a lot, but we still have a long way to go. And so far for the adult KD study, our total enrollment as of October of this year is about 610, and we do divide it up between cohorts and people. So controls are people who never had Kawasaki disease, you know, are fully well, didn't have any history of it. So we have about 147. These control patients are really important for us because they're people that we're able to compare our patients who did have Kawasaki disease. So we're able to understand health outcomes in terms of those who didn't and did have KD. And then in terms of the KD patients, we have about 463. And in those, we divide them into two cohorts. So those of cohort 1 are patients whom we saw from their initial diagnosis at Rady and were treated. So we know from the beginning what they received, what their coronary arteries looked like, how their stats were, their blood, all their vitals. We have all that information and we track it until they're about 18, have their exit visit, and then ideally track them later on through the through the adult KD program. Then our cohort 2 patients are those who were treated at other institutions. As I was stating before, we have people who are out of state, out of the country, who maybe didn't find out that they might have had KD until, you know, they had a heart attack or something at the age of 35, and then went to the doctors and their cardiologist was like, you might have KD, you know, look into it. And then they fall into our study because they reach out to us and can enroll in that way. So what does the study involve? So our study involves an online detailed health questionnaire. It's very quick and easy. It takes people about 10 to 15 minutes to fill out, and it's all, you can do it on your phone, on your tablet, on a desktop, an iPad. So it also requires a follow-up health questionnaire every 2 years. So as I mentioned before, ideally we would follow participants for about 20 years. And then after your initial health questionnaire, from that one, every 2 years, you should receive one to the email that you provide me with. And then an optional blood sample for subjects that are in San Diego. We do have subjects who sometimes, you know, they're part of cohort 2 and they are, let's say, from Oregon, but then they reach out to me and are like, hey, in a month, I'm going to be in San Diego. I would love to donate blood for the study. People are able to do that, but ideally the blood sample is a lot easier for patients who are in San Diego already. And then many may ask, you know, why only a health questionnaire? So the health questionnaire is really thorough. It does take people about 10 to 15 minutes. And it's a lot of health history. You know, it asks you about how your Kawasaki disease treatment was, what you did, how it was that you came to it, if you've spoken to a cardiologist about those things. You know, do you have a history of heart issues, diabetes, things like that? So we're able to take all of this information and do a comparison between adults who have a history of Kawasaki disease to other adults who either had KD and had aneurysms, or had KD, no aneurysms, or didn't have KD at all. And this really allows us to gain better insight and understanding about the long-term outcomes for KD patients. And then you may be interested, you know, who can participate. So all people honestly could participate. So KD participants, so those who would fall under the Kawasaki disease cohorts, would be adults obviously who had KD in childhood. We do have patients who reach out to me and are like, I'm not sure if I had KD, you know, I had this certain disease that might have seemed like KD before. Given a lot of the time, we do have the issue in some health systems and healthcare providers that patients will come in and present, you know, some of the symptoms of KD, but will be kind of like misdiagnosed with having scarlet fever or any other disease that has, you know, a rash, a fever, bloodshot eyes, things like that. So we kind of help our patients and our participants figure out where they fall into our study. And then our control participants are adults who've never had KD in childhood. So really, we don't discriminate. Anyone can truly join the study. And with that, I am always looking for research volunteers. It's always better to have more research candidate or participants than less. The better, the higher the numbers, the better the odds in understanding the research and just having more information for us to compare. And with that being said, if you ask yourself the question, did you join this call to learn more about Kawasaki disease? Did you or a loved one experience Kawasaki disease? Do you wish you could contribute to the research of KD? Seeing all of the presentations from today, are you like, wow, I wish I could, help in some way? If you answered yes to one or all of these questions above, you can join and you can join the study today and be part of something bigger. I have provided some QR codes here so you can scan them with your phone if you'd like. One of them is for our website, the other one's for our Instagram that I just recently launched. And then you can always email us at adultkdhealth@health.ucsc.edu. And there you can reach out to me, hey, I was at the symposium, I saw your slides, I saw our presentation, I'm interested in learning more. Or maybe even, I have a friend whose friend of a friend had a child who had KD. You can do that. Let them know, send them this information, send them our website. Our email is easier, our Instagram as well. I'll constantly be posting on there about twice a week about our study, about Kawasaki disease, things like that, to keep people updated and educated. Always our main goal for the adult KD study, as with any research study, is really to understand and be able to educate people more about this rare disease. And then, yeah, if you guys have any questions, please let me know, reach out to me. I will answer you as soon as I can. And then if you're interested or even curious about the study and helping us gain more participants and get closer to the answers of Kawasaki disease and understanding the disease better, please join the study and reach out. Thank you. And then I believe I'll pass it on over back to Audrey or Jane.
We're actually going to have Charles Copeland.
Oh, okay, Charles.
The floor is yours, Charles. Thank you.
Hello, everybody. I'm here to share with everyone some new insights we're getting on Kawasaki disease from work in environmental epidemiology. So why do we use environmental epidemiology to study KD? The cause of Kawasaki disease remains unknown. It's still a mystery. Doctors have gotten very good at diagnosing it and treating it despite this fact, but a breakthrough actually trying to figure out what is the original cause or trigger of Kawasaki disease could have many benefits. One that we're very hopeful about is diagnosis. If we know that there's a particular agent that causes Kawasaki disease, maybe we could use that information to create a quick and accurate way to diagnose it, make sure it gets diagnosed quickly and not missed. We have evidence that there are environmental factors. You've seen some of this evidence from some other talks. There are many basic facts, like the fact that Kawasaki disease tends to have a seasonal cycle. Many reasons to believe there's something in the environment. So what we do with environmental epidemiology, we answer questions or collect facts about the epidemiology, things like where are kids getting sick, when, who, and how many. And we compare that with various environmental factors that could be relevant to these cases. When we combine these two approaches, we can use that to narrow down the list of possible causes and identify which clues about this disease are true and which ones are false. So an example of a false clue might be the fact that for many parts of the world, there's more Kawasaki disease seen in winter, but it would probably be false to say that snow has anything to do with Kawasaki disease. And by comparing the epidemiology and the environmental science, we can collect which of these clues are true and actually leading us towards something about this disease. we tend to focus on data from Japan, and I'll explain a bit of why we do that. To prove environmental effects, we need a very large number of cases, ideally over many years. Japan has a large population and also a high rate of Kawasaki disease due to a presumed genetic predisposition. Additionally, in Japan, there's been an extensive effort to collect hospital data on Kawasaki disease cases in Japan for decades, thanks to the works of people like Dr. Nakamura and many others. Because of this very careful work, we have information about more than 400,000 cases of Kawasaki disease over many decades, including information about the age of patients and what geographic regions in Japan they're recurring in. This graph on the right shows, the rising incidence of cases from the 60s. And because we have such fantastic data, we're able to see varying between times when there are many cases, few cases, and try to explain what is different about the environment. Another fact about KD that we have discovered that is very helpful for this work is the fact that we think, or we have very strong evidence to show that Kawasaki disease comes in clusters. If Kawasaki disease happened randomly, cases would be more spread out across time. Instead, what we actually see is that you get clusters of many cases happening at the same time, and also low periods where you have less Kawasaki disease than is expected if these cases were random or not connected. This suggests that there's something common happening in the environment that causes many kids to get sick at the same time across related but sometimes wide geographic regions. So this graph is from a recent study on San Diego data, where across many years, we show the number of cases per day. These blue vertical lines are times that we believe a cluster of Kawasaki disease cases happened, defined as more than 5 patients within a 7-day period. So you have times when there are not clusters happening, and then times when many people got sick, and we think these are related. This is something like a mini epidemic happening. Because we have, this cluster pattern, we think we can find something common in the environment to explain these. So I study the winds, and I'll explain a bit about why we think this is a good approach. This picture on the right is showing Southern California during a Santa Ana wind, where you can see dust spreading across these wide geographic areas. For Kawasaki disease, past studies have found evidence for a relationship between wind and Kawasaki disease. We could explain the story of Kawasaki disease by theoretical KD-causing particles blowing on the wind, possibly across long distances, and entering through the nose and mouth, triggering the immune and inflammatory response. This story would fit with our epidemiological evidence, but there are many possible things that can blow across the wind that could plausibly cause this. Viruses could spread across the wind, could be fungal spores, there could be a pollution story. Because there are these, different possible ways the story could go, we want to answer basic questions like, where was the wind blowing from when there were many cases or during a cluster? Where was the wind blowing from when there were relatively few cases or a low period? Can changes in the wind explain why some years have more cases than others? And can the wind explain other clues, such as Kawasaki disease's seasonal cycle? Then we want to use the answers to these questions to get closer to KD's ultimate cause. So I'll talk a bit about how we actually model the wind. How do we get the best possible estimates of the wind relevant to Kawasaki disease cases? Because some of these clusters that we see are very specific in terms of their time, we want very accurate models of where the wind is blowing from. The atmosphere is chaotic, turbulent. As you see as this photo from space, there's a lot going on. And sometimes it can be hard to predict the weather far into the future. You run into similar problems predicting the winds forward and backwards in time. So I'll talk about how we've tackled this problem. We rely on this thing called weather reanalysis data to predict the best possible estimates of the wind. The way this data is created, other scientists have collected global weather records from weather stations, satellite measurements all around the world. They take those records and they run the best modern supercomputer weather models on this past data to fill in the gaps between weather stations and other gaps in the data. And this creates something we call weather reanalysis, which creates for us the best possible estimates for past wind around the entire globe. The current state-of-the-art model gives us really, really good estimates of historical winds for every single hour from 1950 to the present, the entire planet at a resolution of less than 20 miles, and altitudes from the surface to what is happening with the wind all the way up to 50 miles above us. And then we use this wind data to answer questions. I primarily use HighSplit. It's the computer program that predicts the movement of particles in the air based on wind data. This program was originally developed decades ago to track radioactive particles in the Cold War. So countries were using similar methods to see where other countries were conducting nuclear tests. But now it has many other uses, like modeling dust storms, wildfire smoke, and sources of pollution. And we can use this to go back in time and help see where the wind is blowing from, where particles, theoretical particles, may have come from. So this picture shows one example of a model run to see where the wind was blowing from that ended up in Tokyo on this particular date, December 1st, 2014. So Tokyo on this map is this purple star. These blue dots show where the wind is likely to have come from 1 hour before. In green, you can see where the wind likely was 6 hours before. So wind is likely to come from the west and also kind of spread out across this region of Japan. 24 hours before, the wind comes from even further away and is spread in this kind of arc from China to Japan. And 48 hours before, the air people were breathing mostly seems to have come from over mainland China, but could have come from as far away as Russia. So we use this kind of data and these models to start to answer questions that we need to figure out this environmental epidemiology. So I'll give a sneak peek at the kind of analysis we use for these models. This is an example of a study we did of this particular cluster of Kawasaki disease cases we saw in January of 2014. On the left is a map of the source wind for these particular dates. The way you can read this, in the darkest red is the areas where you're most likely to have seen wind coming from. Yellow is also a high likelihood that the wind was blowing from that direction. Blue was the least likely, and in white, there's essentially 0% chance that the wind was blowing from that region. In the middle shows the same thing, but not just for these dates, but for that time of year across multiple years, across, in this case, a whole decade. So that's in the middle showing what is the average for that time of year. And then on the right is showing how are these dates from 2014 different from what you would expect for that time of year. And what you can see in the darkest red on this map, these are areas where you had twice as much or more wind blowing from that region compared to all other years in this decade. And we can use this kind of information to try to see, does this difference in the winds, could we use that to explain why you had a cluster of cases at this time of year? Do we see this with other clusters? And that's a short way to explain what we're doing. We're kind of comparing multiple of these clusters, seeing what they have in common, and trying to pull together a cohesive story of, what clues can the wind tell us. So this is very interdisciplinary work. We have experts in medicine, biology, experts in the earth sciences, and we rely on collaborations And of course, the fantastic and very careful data collected in Japan. So really standing on the shoulders of giants here in this kind of work. Because we have such a fantastic team of people, we're really hopeful that we're going to answer these questions and we really think we're going to be able to nail down the cause of Kawasaki disease using these kind of tools. Thank you for listening.
Thank you, Charles. Always amazing. I love the work that we do because of all the amazing scientists that we get to work with, including you and the rest of the climate team. So thank you for sharing that information with us. So now we're back to another Q&A session. And as that's the end of our talks this morning, thank you for everybody for joining us. So I'm going to go ahead and ask folks that spoke, if you guys can turn on your cameras and we'll get to some questions here. For our families out there, feel free to type into the Q&A and I will try to read and distribute appropriately. So one of the questions that came up, and we have one of the resident experts here with Dr. Burns, is about carpet cleaning and with the initial hypothesis. I know that we're also joined by the other co-author, Dr. Glaudet, this morning on the line. So there's a couple of questions about having KD immediately after carpet cleaning, and is there any further research in terms of that or cleaning products and its association as a potential trigger in KD?
Well, I love the question, which is near and dear to my heart. And sharing with Dr. Glaudet in Denver, who I think is also on the call or on the symposium. In 1982, we had an outbreak of Kawasaki disease in Denver, Colorado. And Dr. Glaudet was my mentor. I was a chief resident. And the CDC, the Centers for Disease Control, sent a team to Denver to investigate it. And the upshoot of that investigation was that an association was found between walking or crawling on a carpet, a freshly cleaned carpet. It didn't matter whether you used chemical or steam or whatever. You had to walk or crawl on it within 4 hours of the procedure. And if your child did that, you were more likely, compared to controlled families, to have a child who developed Kawasaki disease. And this was investigated subsequently by the CDC again and again and again, actually 8 different times. And in 4 of the investigations, an association was supported. And in 4 of the associations, including one that we did here in San Diego, there was absolutely no relationship. So going back to the epidemiologic data that Charles shared with all of you, and looking at the Japanese data and in looking at the analysis that was done during the pandemic, we saw a dramatic decrease in the pandemic in school-age children and children who are out and about, but infants had no change in the number of cases. And this was true during the pandemic, and it has been true over the decades where the Japanese have been recording these records, these very careful epidemiologic records. So it brings us to the idea that the infants, unlike older children, are being exposed to something in the household. And with the idea that you breathe in whatever the trigger is, we are actually working on a grant application where we hope to do air sampling within the home of our infants down on the ground where they walk and crawl, to see if in KD households versus control best friend households, there's a difference in the microbiome. That would be all of the organisms that get aerosolized. So it's not a crazy idea that when you shampoo or clean a carpet in some way, you create an aerosol, you wet things, and then you create an aerosol. And of course, it would be great fun for Dr. Glaudet and myself if our career came full circle and it turned out that a thing that can trigger Kawasaki disease does in fact get aerosolized from the carpet. So jury's still out. We absolutely don't have any conclusive data on this, but we're going to pursue it because it's one of the avenues that's been dangling out there as a clue for all these decades. And now there's some epidemiologic data that really strongly supports the idea that that the infants, the very youngest infants, are being exposed in the household. And obviously, if you're an infant, less than a year of age, you didn't get very far in your life before you breathed in the thing that triggered it. And since infants tend to spend most of their time in their home, that's where we want to sample the air and take a look at that with our climate team. So that's what I can tell you. Stay tuned.
Thank you, Dr. Burns. And Dr. Drummer, there's a question about long-term side effects from medications like rivaroxaban and aspirin for a child that has giant coronary artery aneurysms. So is there any side effects that you see with those medications?
So we don't really have data on long-term effects of those of direct oral anticoagulants. I mean, not yet, because the medications are fairly new, but the general risks that we think about in using those medications, the systemic anticoagulant medications, have to do with the risk of bleeding, really. I mean, older people have issues related to, stress ulcers, gastritis, GI bleeds, things like that. We haven't seen that yet in our children population, our child population that we've used this in, but we are just about to publish a short research letter about our 24 patients that are on direct oral anticoagulants like rivaroxaban, apixaban, and as we follow these people over time, we will have more knowledge about side effects outside of bleeding. But so far, that's the first one that comes to mind. Children on antiplatelet therapy also, when they get a paper cut or when they cut themselves, they will bleed longer. So they need to hold pressure longer. They can have nosebleeds that require packing or an ENT procedure. We've seen that before in some of our patients. There are some patients who take aspirin and they don't really get blood thinning like we want, or the platelets don't react like we want. And so some patients actually have to be on higher doses of aspirin. There's different ways of looking at the blood to make sure that the patients are on the right amount. But, really the risks have to do more with bleeding. We've rarely seen anybody who was thought to be allergic to aspirin. I think one time we've seen that, which is super, super rare. We don't worry about Reye's syndrome because the patients are on such a low dose of aspirin. So, I mean, I don't know. I mean, if Dr. Burns has, or Dr. Tremoulet has any other longer term knowledge about it yet, but our longest patient has been on a DOAC for, I think, 8 years now. Just 8 years. So
yeah, that's all I think what we know so far, right, Dr. Burns? Anything else?
Yeah, I think that for the patients who are on additional medication with a statin, we do monitor yearly in the same way that adults get monitored for liver enzymes to make sure there's no toxic effect that we see on the liver, and none has surfaced. There is a story in adults about muscle stiffness, muscle aches, muscle discomfort, and we haven't seen that in our population of children. But again, it's a small group of people because these are only the patients who have giant aneurysms or remodeled but still persistent aneurysms. Those are the people who we put on atorvastatin. So we do monitor it yearly. One of the concerns when Dr. Tremoulet started this whole clinical trial that established how we dose it in our smaller patients, a weight-based dosing, one of the concerns was that it might affect brain development because cholesterol is really good for you in many ways, and your brain is made of cholesterol, so we don't want that to go too low. But Dr. Chisato Shimizu in our group actually measured the circulating levels of brain cholesterol and showed that that's not affected by being on atorvastatin. That had never been done before. So we think it's very safe from that point of view. We also didn't want the cholesterol, the blood cholesterol level, to go down too low because that seemed like a bad idea. And I think during the trial, Dr. Tremoulet can correct me, but I think there were maybe 2 patients where we we got down to a level of cholesterol that we thought maybe we would stop the treatment or at least pause it. So we do monitor that on a yearly basis.
I did also see a question in the chat about the age group. So we use atorvastatin down to 2 years of age, less than 2. There's like a research use, right, for 1 to 2 year olds or something like that. But we use it routinely down to 2.
Yeah, and then there's also a question about long-term studies of children on statins. So the study that we did here was during the acute period with children with aneurysms that were going to be on statins for 2 to 6 weeks. Our center and others are now starting to use statins in children with ongoing aneurysms, and I think that's a future area of study. Of course, there's monitoring that happens, as Dr. Burns mentioned, of children on statins because we're not treating them to get their cholesterol to be lower. We don't want it to be lower than certainly usually like 100 milligrams per deciliter. So we do monitor that, and I think there's work to be done on the long-term use of statins in children with persistent aneurysms. So there was a question also, I think, Dr. Burns, about that you can answer about the adult study. I know that in years past, Dr. Daniels and others have shared some of the results from the adult KD study, and so there's a question about any results or any analysis that's going to happen in the future.
So with the funding that we generously have from the Gordon and Marilyn Macklin Foundation, we'll be enrolling patients up until July 1st of 2024. And at that point, we will close the study to further enrollment and just continue to follow the cohort that we have. So we are eager to get more people enrolled. I hope everybody clicked on the QR codes that Angie showed. The future analysis that we want to do is on the next cohort enrolled since the last analysis was done. The last analysis had some concerning findings that had to do with chest discomfort, exercise intolerance, and migraine headache. As a signal that was there in our KD patients, even those who never had any aneurysms. And we were left not knowing if that was an artifact of small numbers, because it was a small number of patients that were analyzed. There was also a concern that some people might have depression or anxiety or other more emotional problems that could feed into some of those symptoms. And that's always a push me, pull you issue with cardiovascular symptoms, is that stress can intersect very importantly with signs and symptoms of cardiovascular issues. So we really just need to expand the numbers of people enrolled, and we'll be coming back to test those hypotheses or those observations that were made on really a small cohort of patients, and we hope to have much more robust numbers to either support or disprove those previous observations, preliminary observations.
Great, thank you. There have been a couple of questions also about any connection between Kawasaki disease and the hyperinflammatory syndrome that happens 4 to 6 weeks after being exposed to COVID, which is known as multisystem inflammatory syndrome in children, MISC, or in many parts of the world also as pediatric inflammatory multisystem syndrome, PIMS. So our we covered this in a lot of depth last year, but gratefully MISC has, I hope, it's mostly disappeared, and it's a disease that causes a lot of inflammation that has overlapping signs and symptoms with Kawasaki disease, and there's inflammation similar to what happens in KD, but to a much higher level in MIS-C patients. So while both diseases do share an overlap in the pathways that are increased in children with both of these diseases, they are in fact 2 distinct diseases, and can be between labs and other things, we can generally tell those 2 apart. And as I mentioned, for whatever reason, and maybe it's because of pediatric vaccination, which we know also reduces the rate of MIS-C. If it's that the variants have changed and are no longer able to cause as much inflammation, we're happy to see that that disease has really significantly diminished. And I frankly hope it never, ever comes back.
I wanted to just add really quickly that there is a big difference between Kawasaki disease and the PIMS or MIS-C in that we don't believe that MIS-C and PIMS and this post-COVID inflammatory response affects the heart like Kawasaki disease does. So we don't see aneurysms in the MIS-C PIMS patients. We do see a lot of cardiac shock. The heart muscle gets very shocked by all the inflammation and then it recovers. So if those children are treated using similar medicines as we use for Kawasaki disease, all of our patients, we've had 123 of them, all of our patients have recovered their heart function, even if they're very, very, very sick in an ICU. So even though there is a very small rate of death really related to MIS-C, it was because I think the world didn't understand what it was. And hopefully we don't see a lot of it anymore, although I was just on a phone call with 30 sites that participate in this study. And in some cities where they saw a big bump of COVID in August, they are seeing some scattered cases of MIS-C, largely in unvaccinated kids. We didn't see MIS-C in any of the vaccinated children who had received COVID-19 vaccines. So there's some protection if the children are vaccinated. I just wanted to add that little part.
Yeah, thank you. That's all very, very important. So there are some questions that I think, Dr. Burns, I'm going to ask you about a patient or a parent that said, is there any way that my 3-year-old who was diagnosed in December of 2022 can contribute to any of your ongoing research studies? So maybe if you just want to address what studies we have available to children after being diagnosed with KD.
So I don't know whether your child developed aneurysms or not, but for our genetic study, which is one of our major ongoing studies, where we're collecting DNA from families, but because of limited resources and limited person power, only from families where there have been aneurysms or where there are multiple affected members of the family. Cousins, for example, if we could collect DNA from the cousin and the cousin's parents and your child and the biologic parents, that can contribute to our genetic research. We just don't have the bandwidth or the funding to collect DNA from parents and children who had no cardiac damage from their Kawasaki disease. But you can reach out to us through the email kdgenetics@ucsd.edu if you are the parent of a child with aneurysms and you'd like to contribute that way. In terms of the adult KD study, as Angie said, that's for people 15 years and older. There are consent forms that have to be signed, and we need individuals to be at least 15 years or older. So if you're an adult listening to this, you can contribute to our research that way. I know some people don't consider 15-year-olds to be adults, but that's our definition for the study. And those are really our big ongoing research studies where we're collecting samples from the patients who present. So the patient that I admitted to the hospital yesterday here in San Diego, we approach all of our families for contributing blood samples before treatment. And those are the blood samples that really help us to learn about what Kawasaki disease is, to fuel the kind of research that Dr. Wang is doing, and our bioinformaticians about looking at big data. But those really have to be samples collected here at Rady Children's Hospital and collected before the patient is treated. So thank you for your offer. When your child turns 15, reach out to us again.
So Dr. Doomer, there are a couple of questions about the use of different anticoagulants. One question specifically I thought that would be important to address is comparing adult data from patients on warfarin versus direct oral anticoagulants. If you could speak to any work there and the difference in medications.
Yes, that's a really good question. I think we talked about this a couple years ago in the Parent Symposium. So warfarin is currently a standard of care medication for systemic anticoagulation in giant aneurysms. Warfarin has a lot of drawbacks to it. It has to be, it has a very narrow therapeutic range. The labs have to be obtained, frequently. There was one study that showed that the time that the patients with Kawasaki disease were actually therapeutic on warfarin ranged between 40% of the time and 60% of the time, which is somewhat frightening because the patients on warfarin are on it because they have these giant aneurysms. And so the biggest concern and the biggest risk related to the aneurysms is clot formation in the aneurysms, and then essentially a heart attack because there's decreased flow to the muscle. So warfarin is, it's tricky. It's not a very good medication, and there are long-term side effects that have to do with calcification of vessels. So there's a lot of research that's done on a certain percentage of the population on warfarin that basically accumulates calcium in the walls of vessels in their body. We have seen teenagers on warfarin for heart valve issues that you can get a chest x-ray one day, 15 years later, 20 years later, and their entire airway is lined in calcification, and it's directly related to warfarin. We don't know yet which patients are at higher risk. It's going to be another story about genetics and predisposition and things like that. But the long-term effects of Coumadin can be bad, and it's not a good drug to keep somebody with thin blood for their aneurysms. So those are the concerns we have with warfarin, and that's why we chose to offer our patients on long-term medication to switch from warfarin over to, these direct oral anticoagulants like apixaban and rivaroxaban. These medications, these newer medications, are also being used in a lot of other populations, including premature babies with clots in the NICU, including certain types of cardiac patients, not yet valve replacement patients, but other types of patients that require blood thinning. And so they are safe medications. They do not require lab monitoring. Sometimes we will send a lab to help us understand what the level is if we're worried about non-compliance. If you don't take your medication, obviously it can't work as effectively. But they are, it's a twice a day medication. It's taken orally. We have a liquid preparation for children. The youngest we've used it down to is 18 months of age. As these medications became more available, particularly in the adult community, we didn't worry as much about reversal agents, like if there was a trauma or head bleed or something like that. Now those reversal agents tend to be really widely available, but we have really encouraged our families to switch because we think it's a better medication and easier in terms of lifestyle and things like that. Did that answer it?
Yes, thank you. So there's a question about updates on KD diagnostic testing. I know that we didn't get to that today. We have covered it in years past. I'll answer a bit of that, and I'll let Dr. Burns chime in as well. There's a lot going on in terms of diagnostic test development that our team and others around the globe are involved in. And there's been some really significant progress, I think, in that arena. Last year, we addressed an algorithm that we're working on in conjunction with Shamim Namadi's group here at UC San Diego and Jonathan Lamb, called KidMatch, which is a quite simple in terms of the end user. It requires the physician to put in what clinical signs of KD they've seen and some basic labs that most people around the globe get when evaluating a child for Kawasaki disease. I can share with you, as we shared last year, that that algorithm was initially designed to actually distinguish between MISC and Kawasaki disease and children with other febrile illnesses, and did so very well. We're now working on another iteration of that, which really distinguishes between KD and children with febrile issues due to something other than Kawasaki disease, in part because MISC has mostly disappeared, except for some rare cases that we're hearing about. So there's a lot of work going on in that arena. I think I'm going to let Dr. Burns also speak to some fancier platforms that are being designed in conjunction with our collaborators for diagnostic test development.
So there's a patent that has been licensed by a company in the Netherlands called Skyline, and it's a PCR-based study which uses transcripts, 13 different transcripts. So this is the kind of measurement that now all major, particularly university or large medical center laboratories have the machines to actually run this kind of platform. And that is in the process of being commercialized. The reason that we need for industry to pick up the ball on these different proposed tests is that they really require testing in large populations of people. And it's not even possible to do that kind of large scale testing when you just have a manual kind of test development or testing to get the results. So it really has to be incorporated into the kind of big machines that are run and used in hospital laboratories. So that's in process. Our wonderful collaborator with whom we have a lab meeting every week in London, Professor Michael Levine at Imperial College in London, also has partnered with bioMérieux, which is one of the big diagnostic companies, and they have a pouch that runs on a machine that's already up and running in most hospital laboratories called BioFire. And that pouch is 44 different transcripts, and that diagnoses or differentiates, we hope, Kawasaki disease from a whole variety of other causes, infectious diseases that can affect children. So that's now being put into the hospital setting in clinics across the UK and Western Europe. 3,000 pouches have been manufactured, and they're being tested to see if it works. There's a push me, pull you here with cost, and that's clearly an issue. So there may be other iterations of that test that can shrink down. The 13 transcript panel that Skyline is developing that just does Kawasaki disease may be a more economical way to go. So we on the research end can do the research to get these things to the point where they need to be taken up by industry. Once they're licensed and taken up by industry, actually forcing those companies to be fast about getting them into the market or into a larger testing situation, we kind of lose control over it at that point, which is just the reality of where we are in terms of diagnostic test development. One thing that I want to mention, there are some other tests out there that have been widely hyped in the news media. And I just want to say that we have to be very, very careful when we see a lot of this hype coming down the path, that the testing that was done for these panels or these putative diagnostic tests, that the comparison group with the Kawasaki disease patients was really a valid and appropriate control test group. So no physician needs a test to say this is a healthy person versus this is a person who has Kawasaki disease. And similarly, no doctor needs a test to say this is Kawasaki disease versus somebody who has RSV or a respiratory virus or influenza. That's not a useful comparison. And so I just worry that a lot of the things that are being published or a lot of the things that are being hyped by media are actually tests that haven't perhaps been appropriately or rigorously tested to the right control population. And they may be great, but they haven't been tested in the appropriate way. So there's a lot that goes into coming up with a test that in the long run is going to be robust and works well. And we're really interested in what happens with, we're going to call it KidMatch 2.0, which will be the new version of the computer algorithm developed here at UCSD. Because of course this would be inexpensive. And the decision has been made not to commercialize it, but to actually make the code widely available, so it could be incorporated into a hospital computer system. But first it has to be adequately beta tested or prospectively tested, we hope, in our Rady Children's Hospital emergency room before we want to unleash it on the world.
Great, thank you. There's one other last question that I'll answer here about staying in contact. I know that the KD Foundation is an incredible resource for our families from around the globe, and there's other KD parent groups around the globe as well, where parents can stay in contact and reach out to each other. Also through the KD Foundation, there's a program called KD Foundation Bridges, where it helps families get their questions answered and to stay in contact with each other, with other KD families. So we encourage you to go to kdfoundation.org for further information. With that, we've come up at the end of our time here. I'm going to let Dr. Burns close us out, but just a sincere thank you to everyone, to our translator, who's a KD parent. Thank you so much for joining us, Lucia, this morning, and to all of our collaborators. Dr. Burns, I'll hand it over to you.
Just to add a thank you not only to the presenters today, but to all the families who have participated in our research. We hold this every year. This is the 15th annual Parent Symposium. We're going to keep on doing this because this is our way to try to thank you for the support that you give to our research. So thanks to everybody. And we'll see you next year.
Thank you, everybody. Or see you in Montreal for the KD Symposium. Watch out for that, for the recording. Thank you so much, everybody. Have a good rest of your day. Take care. Bye-bye.